All right, hello and welcome to another episode. Today we have the pleasure of having Dr. Michael Moutoussis, who is a clinical lecturer at UCL. He earned his specialist medical registration as a psychiatrist in psychotherapy in 2009 and completed his PhD afterwards in the experimental and computational study of paranoid delusions. Welcome to the show, Michael.
It's lovely to be here.
Great. So, just to start things off, how will you tell us about yourself in relation to your clinical experience and career as a psychiatrist?
Yeah, so I've always had an interest in science, and in fact, my first training was not in medicine, but in science, and specifically in physics. And then I was inspired by the plight of psychiatric patients in particular, who I thought were generally ill-served. There was a bit of a Cinderella specialty. And in those days, when I was sort of much younger and energetic, I thought I would devote myself to that, which I did. And got qualified in medicine first, which I found very interesting, and psychiatry. Um, but it was obvious to me that the ideal of the biopsychosocial understanding of a person, something that not only um, focuses on a diagnosis, but an understanding of the patient as a whole, the whole biology and psychology and social circumstances. That ideal was something that we still need to work towards. And then the opportunity came to actually adopt a computational approach to research psychiatry. And I was very lucky to do my PhD back in the day while I was actually also in higher training in psychiatry with someone called Peter Dayan, who was a pioneer in the field and very much had time and thought for psychiatry um, and how to approach it through a computational neuroscience lens at a time where that was actually not on the cards.
Hmm.
Um, so I've been particularly interested in the application of computational neuroscience to learning-based treatments um, because I it is obvious that the brain is an organ of learning, and we use learning to change the function of that organ all the time through education and development and so on. And we do that in psychological and psychiatric treatments, for example, in rehabilitation treatments. Um, so I thought that it was very natural to use computational psychiatry, which deals with learning and inference, with how we actually draw conclusions about the world and how we learn from them. I thought it was very natural to apply that to psychiatric research. And that was at a time where um, computational psychiatry was mostly used in the hope that it would provide better diagnoses and
Mhm.
would actually be more in line with a medical model where we make a diagnosis and then we have a biological intervention, particularly a psychopharmacological one, to correct some deficit or bias or disease process. Um, so I much prefer the wider biopsychosocial approach,
Mhm.
where learning has a key role, an explicit role.
Mhm.
Um, and so I'm using computational psychiatry um, with that lens.
So, is it fair to say that the computational psychiatry approach is somewhat new or budding at least?
Well, the term computational psychiatry as such is fairly new. It must be, I don't know, 15 years old or so. The idea that we use mathematical and computational models in psychiatry goes back a lot further and has gone through a few different generations of research. And usually with each wave of these research, there was hope of breakthroughs. And what actually happened was that these waves made important contributions to our understanding of psychological and psychiatric disorders, but didn't really cause a revolution as such. They were a revolution in their field, but as far as mental health is concerned, not. The process was incremental. So now it's sort of called computational psychiatry, and the idea is that there's emphasis on the computations that the brain performs in order to carry out its functions. But the approach as such to use computational methods stretches back at least to the 1970s.
Well, how does this differ from, let's say, traditional approaches to psychotherapy? I mean, I guess the difference is the computational part. But yeah, I guess to somebody who hasn't heard the term before, how would you describe the differences exactly?
Psychological therapies in general have got their own models which say how information is processed in the brain or is processed by the mind. And there are many, many such models. These models are either not researched quantitatively, they come out of people's clinical experience, and they are established before there's any quantitative sort of hard evidence for them, or generally they are researched in a kind of conceptual manner quantitatively. For example, if I have a theory that depression depends on attributing negative events to the self and positive events to the outside world. So that's a theory about how depression works that is used in therapy. What I would do is I would go out and create an instrument to measure this particular construct. So the construct would be attribution of negative and positive events. And I would ask a person, 20 questions, if this happened, if you, for example, you did very well at school, what would be the cause of that? And the person would say, oh, the cause of that would be that the exam was very easy. And that would be an attribution of a positive event to an outside circumstance. So I would actually put together an instrument that has got these questions. I would give it to people, and I would have a score about the measure that I hypothesized. So in this particular case, whether positive outcomes are attributed to the self. And then I would go and examine the properties of this instrument, and I would say, yes, this instrument is reliable. If I give it to the same person a week apart, I'm going to get a similar score.
Mm-hmm.
I might say, yes, this instrument is valid because it correlates with this other instrument that other people have actually.
So kind of like the factor analysis and test-retest reliability, right?
That's right.
Okay.
That kind of thing. So I would establish my instrument, and then I would compare a group with depression and a group without depression. Or I would compare people at risk with depression, people without a risk of depression. So this is all great quantitative research, but it would be about testing a conceptual hypothesis in a quantitative manner. Now, if I wanted to do something like that computationally, it would be a little bit different. I would have the sort of diagram that I would write down about how information is processed in the brain. I would express with equations and with code. And then I would have a laboratory task, or maybe I would do real life measurements, repeated real life measurements, but that's a bit harder. But for the sake of this conversation, let's start from having a laboratory task.
Yeah.
Where people would learn from outside, from positive and negative events. And I would have some kind of decision making that I would record, and I would see how well my model, which is now composed of equations and predicts what's going to happen from trial to trial as the person is exposed to these positive and negative events. And I would see how well my model describes this same sort of how the model captures the hypothesis and explains the data. And then that would be quite useful because I might relate it to neuroscience. I might actually have this person perform this task in a scanner, for example, and see what parts of their brain record these positive and negative inputs, and whether, for example, people with depression and people without depression might differ in their responsivity, in their neurobiological responsivity to these measures, and so on. Does that give a bit of a picture of what the difference is like?
It sounds like there is, it's much more powerful in the sense that you can have more variables and then measure them quantifiably, and then apply things like maybe weights and biases to model the behavior, let's say, or what kind of predictions can come out from there.
So it is powerful. It is rigorous. It allows you to describe behavior in a very quantitative way, and it relates to. It is more easy to it is easier to relate to neuroscientific measures. It's not all. It's not that it isn't more powerful in every way. For example, what we have to do is reduce the person's experience to a laboratory task. And often that means that it is less realistic. Laboratory tasks take quite a bit of time for a person to do, which is not so easy, whereas a sort of a questionnaire might take, I don't know, 5 minutes to fill in, whereas a laboratory task might take 30 minutes and be much longer. And the psychometric properties of these computational tasks are not that great. You only get, so if you say you encode your data in terms of binary decisions, do I say I had the task that I described doesn't exist. I made it up for the purposes of a conversation. But say if I had a task and I had to choose between myself and someone else as the cause of a positive or a negative event. So every trial I choose I say, Benjamin is responsible that this interview went well. Michael is responsible for this interview. Benjamin, Michael. This is a binary decision. It only gives you one bit of information per trial. Okay. So if I have 100 trials, I'm going to have 100 bits of information. 100 bits of information is not a lot. So a verbal task or a language will give you 100 bits of information much more quickly. So in that sense, it is quite a cumbersome way to gather information. So it's rigorous in some senses. It is more objective, but it's no panacea
Hmm.
in that sense.
Hmm. So I guess it's still important, I mean, very important as usual, to operationalize your variables properly and everything. But yeah, it also seems like, as you were saying just now, it may be more time consuming and less efficient as well. Yeah. So yeah, I was gonna mention the pros and cons of the approach later on, but I wanted to get a bit more specific because I spent some time to read your paper on well, the main paper you had on computational psychology, where you were laying out the different terms that you would use, and I think it was on how traditional models of psychotherapy are insufficient at explaining things like avoidance behavior.
Yeah.
Um, yeah, that paper. Yeah, I wanted to ask if I may on what each of the terminologies mean. Um, yeah, if that's all right. So I guess we can start with the concept of state and action and their respective values. Yeah, what does that look like in diagnosing, not diagnosing, but in any example that you prefer to use?
Uh, State and action. Okay. So with these uh with these models and this task, these kinds of tasks, um, you need to write down some equations that say how this person's thinking or learning evolves.
Yeah.
They are somewhere at this particular second, and then they get some observations, some stimuli, and then they go to a new brain state.
Yes.
Okay. And you will want to be able to describe that. Okay. So the what we try to do is put in a state those variables that will allow us to take the the person, the model of the person, from one time point to the next. So the person's state may be described by what's important for this task, for this situation, um, and that will then change with the stimuli. For example, we may have a classic uh, in a classic Pavlovian task, you will show someone a stimulus and they may get a positive or negative outcome
Hmm.
that follows this stimulus. So this stimulus acquires value, and you describe the agent primarily in terms of the value that they learn about the stimuli. So at each point in time now, I say that when the person sees, say, the red fractal and the green fractal on the screen, they have a representation of what the value of those things are.
Hmm.
Then they choose the green fractal, and then they get an outcome, and that outcome makes them learn something new about this choice that they made.
Yes.
So, in brief, I have described to you the way that we usually encode states as being um, from the agent's point of view, from the person's point of view.
Hmm.
Okay, um, and that will allow us to model their beliefs or their perceptions or their values um, or their motivations as they evolve from step to step. Of course, and the advantage of doing that is that it encourages one to be self-contained about this what the person's mind is like at this particular moment. So, for example, that's a very important example. People have memory. So you can actually condense everything that the person has experienced in the past into what their memory encodes about this particular situation or task. Okay. Maybe a person has had terrible experiences with green stimuli.
Hmm.
So they have a terrible value. A starting point of their value about the green stimuli is very negative and also very difficult to shift. So this experience of the person, this memory of the person, is may be encoded in the state of their beliefs about green things and red things in this particular case. And that allows you to do these very, very nice modelings, from time to time, that you don't have to either know or encode all the experiences that this person has about, green things in the last 10 years.
Mm-hmm.
Okay. Um, so, so that's the thing about state.
Wait, sorry, can I just clarify? So, when I think state, because state could mean a few things when I initially hear about it. So, is that a state of the mind or an understanding about the current state of the world? Because, yeah.
So you can, depending on what you're modeling,
Okay.
it could be either of those things. But
Right.
what I'm emphasizing here for the purposes of computational psychiatry is that it is the necessary description of the person's brain, the description of the person's brain, which is necessary for me to understand how they actually go through the experience that I'm trying to model and to understand. So if I want to understand learning from positive and negative outcomes, I'm going to say, okay, my hypothesis is that these beliefs, A, B, C, D, are important for that. And
Hmm.
beliefs A, B, C, D are how I'm going to describe the state of the brain of that person.
Okay.
Okay. So it's not a total description of the world. We so much about states, and usually the states that we use are very simplified compared to either what psychologically or neurobiologically the brain encodes. We are really trying to condense things to a few things that we can study rigorously.
Hmm. Yeah, that makes sense.
Now, of course, if you wanted to say you wanted to understand a person by giving them a computer game, when you do your actual modeling of the task, you would have to have in your state what the computer game did when the person performed this action or that action. But we're not really, for the purposes of science, we're not really interested in the state of the world or the state of the computer game. We may have to do that for practical purposes, but what we are really interested in is the state of the person's brain
Hmm.
as it gets in the information from the computer game.
Hmm. Okay, so it's fair to say it's what they believe about the world at that point in time, right? That would be the state of the brain.
Uh, well, yes, in a very broad sense of the word believe. So
Okay. Yes, I know you make a distinction between belief and effective belief, is what I remember. Yes.
yeah. So it's a very broad sense of belief. It's not belief in the sense that, for example, it is used in philosophy sometimes, that it is a proposition which we consider true. So it's not the sense that it's an explicit proposition which we consider to be true. That's not
Hmm.
what belief is here. It's a much broader idea.
Hmm. And so that encompasses implicit belief as well, right? Um,
Yeah, that's right. That's right.
okay.
So usually in computational neuroscience, when we talk about belief, we mean a representation that is endowed with a certain certainty or uncertainty.
Okay.
So,
Yes.
I may have a belief that there are 20 items on my desk without counting them. It might be that there is 10, it might be that there's 30. I'm not sure. So, but I have got a representation of it, and that representation is endowed with an uncertainty, or
Hmm.
to put it more formally, that somehow my brain represents the probability distribution over the possible true states of the world.
Hmm. And how is that related to likelihood? Because I know that's another keyword.
Um, so likelihood is a term that in computational psychiatry and computational neuroscience we use formally, but it's used in everyday language more loosely. So in everyday language, I could, say, what time is my uncle going to come? He's going to come at, you know, 10 a.m. Okay, what's the likelihood that he's going to come at 9 a.m.? And I mean just probability by that. In computational neuroscience, when we say likelihood, we mean uh, something that comes from there's a term that usually comes from Bayes' rule, and we mean the probability of an event as a function of the parameters of the model that we are talking about.
Okay.
So um, so it is more technical, and the emphasis is that what may have different values is not the outcome of the event. I know the outcome of the event, okay?
Hmm.
But what I think may have different values is a parameter of the model that may account for that event. So when I have an experiment that has got 10 events, okay, I choose a parameter value for my model,
Hmm.
and that gives me a probability for each of the 10 events. So that is usually the summed log likelihood. I calculate the sum log likelihood for that parameter value, which is the sum of the logs of the probabilities that the outcomes that were actually observed,
Hmm.
the outcomes were actually observed would happen if the model had this parameter value. So it's a kind of probability the other way around, if I were to put it that way. The emphasis is on what the knobs of the model, the settings of the models are,
Hmm.
uh, rather than the outcomes, which we know. The outcomes are the data.
Hmm. And so to clarify, because sorry, it might be a bit hard to wrap my head around it, but it's so this is supposedly what's going on in our brains, right? So we are the ones determining these knobs whenever we learn about things or experience things in life.
That's very interesting. So the knobs in so this logic of update of our beliefs can be applied, and that's a really fascinating thing about our subject. It can be applied either from the outside. This is what I think is going on in my model, and I say that as a scientist.
Hmm.
My model's likelihood is this and this, or it can be applied to the person's beliefs.
Yes.
Um, and the belief in this particular case is usually thought about as whether a hypothesis is true or not. Okay. So Say, for example, that I have a mental model that my uncle is going to come at 10 o'clock. And I know my uncle very well. And I know that he's always quite, quite good with his timing, and he would come at whatever time I said. Did I say 9 a.m.? 9 a.m. Um, so the hypothesis here would be my uncle is good with his timing. That's my hypothesis. That's where I come from as a person. Now, my uncle doesn't come at 9 a.m. And the question is, am I going to revise this hypothesis that my uncle is a kind of rigorous person that, keeps his appointments? Or am I going to think about another hypothesis that my uncle had an accident, for example, to explain the observation that he hasn't come? Okay. So here, I have two likelihoods. One is the likelihood that my uncle is late, given the hypothesis that he had an accident. That's likelihood one. Likelihood two is that my uncle is late, given that he's usually good with his timing.
Yes.
Now, the likelihood that my uncle is late, given that he's good with his timing, is low. Okay. So I may go for the hypothesis that he's had an accident. Okay. But now imagine that it's not my uncle, it's someone that I've just met. Okay. In that case, I may actually choose to change the hypothesis that this person is good with his timing to an alternative hypothesis that this person is a bit chaotic. Okay. And consider that people don't usually have accidents. Okay. So now my new state of belief is that this person isn't very good with his timing. He's not very consistent. I can't expect him to be on time. So what I've actually tried to demonstrate here is that when we update in our brain our beliefs, our hypothesis about the world, we take into account both the likelihood, that's to say, whether my hypothesis would produce the observations if it were true, and the strength of our pre-existing beliefs about these hypotheses. So this is Bayes' rule.
Yes.
Essentially.
Okay. So this is so interesting because what you're getting at is the mechanism of inference, right? So it's when I was reading it, because the concept of inference was really interesting because that's I think really the crux of how certain maladaptive ways of thinking occur, right? So is this where it's useful for for psychiatry or psychotherapy?
Yeah, it's very, very interesting, and hopefully it's going to be more and more useful as time goes on. So it allows us to first of all partition the possibility that a particular psychiatric disorder may be due to the wrong likelihood function.
Yes.
So I have a wrong idea about which hypotheses will result in which outcomes. Or it might be that I have the wrong prior beliefs, that that I have a too strong a belief that this or that hypothesis obtains. So, for example, in our research on so-called paranoid ideas. That's to say, ideas that others are ill-intentioned towards us.
Hmm.
We have found that people that have got high scores, that score high on psychometric instruments of paranoia, show stronger beliefs, stronger pre-existing beliefs that others will be ill-intentioned towards them. So
Hmm.
here, the um, the bias for these people in this example is located in those prior beliefs rather than their model of the world of what people that have got bad intentions or good intentions are likely to do.
Hmm. Hmm. Is there a need to further model how inference differs across individuals with certain psychopathologies? Because it seems like a pretty something that you can get pretty deep into the mechanism of inference.
That's right. Yeah, there's we do need a lot more work on this.
Hmm.
Uh, we don't really have such a brilliant idea about how people represent the state of the world. We've got some ideas, but as I say, these are hypotheses on which we build our models.
Yeah.
So we don't know for sure this is true. And yeah, we can go, we need to go much deeper into it.
Hmm. Hmm. Okay. Well, yeah, I mean, as with all things, we just have to keep working towards it. Yeah. I was wondering, one more thing on just the, um, I guess, terminology maybe. Does it account for something like metacognition? Because I've had a lot of conversations recently about metacognition, things like self-reflection, rumination, and I've always found it to be um, essential in where um, certain maladaptive forms of thinking would occur. Because you can imagine a scenario where I have a wrong belief, but if I have good metacognition and have good knowledge that I'm prone to such beliefs, then I would kind of correct myself in that way. Um, and another way I like to conceptualize it is that therapy is a form of external metacognition to some extent, right? It's like somebody helping to criticize your existing beliefs or point out where you might be biased in terms of your thinking. Yeah, so do you see a place where computational psychotherapy can integrate metacognition?
Oh, definitely. Yeah. So metacognition is a very interesting uh, uh, topic. Metacognition is the way in which cognitive neuroscience examines ideas about one's own thinking. And the kinds of beliefs that we've talked about before about how strongly I believe that my own cognition does this or that, um, and how easy it is to change these views. Absolutely, may have a role in describing psychopathology. And in the last few years, there's been a sort of explosion on the issue of metacognition in that sense. Um, the so, for example, the the example that I gave before, I encounter a person and I have a paranoid idea about them, could very well be uh, ameliorated if I had a metacognitive belief that
Hmm.
I am actually not great at judging whether people are ill-intentioned or not.
Yes.
This is something that we very much do informally in psychotherapy. So, um, your viewers may know about mentalization-based therapy.
MBT.
Um, that's an example of a therapy where patients may often jump to conclusions about themselves or others. And these conclusions are usually quite distressing. And the one of the first things that we teach people with this kind of condition in the context of therapy is that such conclusions, although they may feel powerful and true, are actually quite uncertain. So what we're doing is we are enhancing their metacognitive belief that their conclusions in this and this and this area are actually uncertain.
Hmm.
So that's a sort of very fairly straightforward metacognitive intervention that is very common. There is also, as you may know, a whole branch of rehabilitative set of therapies for psychoses, which deal with this in a sort of hands-on way, which they give people little exercises about what does this picture show, and you see the picture stage by stage, and then if they jump to conclusions, which is a bias that takes place in psychotic disorders, you can then educate them and you say, look, you took this decision too quickly. Hang on, sample more information, and then decide. So that type of therapy is incorporates this metacognitive approach, which has been around for a little while, and it's a component of evidence-based therapy for psychotic disorders.
Mm-hmm. Yeah, that's so interesting. So going back to computational psychiatry, sorry, I was wondering what it looks like practically in the clinical practice. I mean, have you used it to inform your practice in the past? And what does it look like in terms of, yeah.
Sure. So the thing is that to actually do to actually carry out an intervention in the clinic, one needs years of research and comparative studies. So it's not so easy, and we don't really have powerful interventions that are based on computational psychiatry findings for a number of reasons, which I can tell you about. But that's not all that happens in clinical encounters. One thing which is very important for patients is that they have an understanding of their condition and how their brain works and what might be going on. And in that context of the psychoeducational content or the educational content about a condition or disorder, I think computational psychiatry already has a lot to offer. So I do use principles of computational psychiatry to talk to my patients about what may be going on, how to see their disorder, and it actually does give them both a picture and it gives them hope for change. But it's actually not, it doesn't go into really the detail and the interventions that I would like to have.
Mm-hmm.
So, for example, people understand quite easily that the brain is not there to represent the world absolutely precisely. The brain is there to model the world, to have an idea about how things are going to go, and that these models that the brain has serve a purpose. And that purpose may be survival, maybe reproduction, maybe sustaining life, and so on and so forth. So the idea that the brain has models of the world, and these models serve a purpose, but they may actually go wrong because they may have the wrong beliefs about the world, is something that people understand, and they find a lot more hopeful than the sort of pure disease model, which
Hmm.
says, you have a psychiatric disorder because your brain is fundamentally wrong, broken, imbalanced, and so on and so forth, which doesn't really have a meaning for them. It doesn't connect with experience.
Hmm. Yeah, this is the other thing I was thinking about, which I was going to ask you later anyway, which is, did you see any potential critique of this approach in being less humane? I know it's exactly opposite to what you just said, but I mean, putting the word computational in front of psychiatry kind of lends it this cold, hard, mathematical, outlook and sentiment. And I was wondering if you had anything to say to dispel that, which, I mean, you kind of alluded to it already, that it makes things more understandable even. But yeah.
Yeah, so I think it has I'm not going to dispel it completely because it has a point.
Hmm.
Um, and the point is that it doesn't really, it abstracts out. When we talk about these models, they abstract out an enormous amount of the person's experience, and they focus on very specific processes. Um, so they, they they can be reductionist, and that kind of critique, I think, is very important to keep in mind. In another way to see it, what we talk about is, in a sense, more humanistic um, than a naive disease model.
Hmm.
However, what we don't talk about may be very important, and we neglect it for the sake of these kinds of formulation. Um, so yeah, I think it's if it's it's something that provides the opportunity for communicating with a patient, for a shared understanding, for basis of learning, for optimism, but at the same time, it has got a risk for reductionism that it might be uh, uh, dehumanizing.
Hmm. Yeah, I guess that just points to the tough line that, therapists and clinicians need to walk, balancing this whole, um, explaining to your patient what you have, but at the same time being understanding of their situation. Yeah. Hmm. Along the same line, do you think the field is divided on the computational approach to psychotherapy? Is there any resistance towards it um, among people in the same field or not in the field?
I think that the field, if you can call it a field of computational psychotherapy in the terms that I've described, is so small that it doesn't really have, um, uh, I don't think, big rifts or divisions within it.
Hmm. But what about external? It's what about people outside? What do they think about it?
I don't think people outside would know
Mhm.
often what it is. There is there is I think one thing that people might outside might say that has got some grounds to it is that, hey guys, this is ivory tower. It hasn't actually boiled the cabbages as yet. It's all
Mm.
great and it's promising, but it hasn't really bought the cabbages. So I think that would be a valid criticism from the outside.
Mm.
And if you came to me and said, Michael, you're spending so much time, testing these models, and hoping that you're going to find out about mechanisms of disorders. Um, but isn't it better if tried out something more, tried and tested? Um, yeah, well, it kind of is, but kind of isn't. You're not going to actually make major progress if you stick to what you
Yeah, of
already
course. Yeah.
know.
Yeah. Don't worry, I'm not gonna say that to you. I think it's great, honestly. Yeah. So I guess that's my final question. What does the future look like for the field of computational psychiatry? Where do you hope it goes to? Oh, yeah.
Well, one of the things that I hope, and I've been working towards, is, but it's actually quite hard to do, is much better integration with other stakeholders in mental health. So I would like to speak a lot more with clinicians who have got clinical problems, and that they would have um, a lot more input into what we're actually, um, where we actually orient our studies, and what hypotheses we actually spend all this time testing in these rigorous ways. So I think that actually to get frontline clinicians to help us help them, that would be definitely a dream of mine. Related to that is to find ways of getting mental health um, service users or patients and people that have got substantial neurodivergence to input into our world and in research in a much better way than they do now. And I think one of the steps towards that is one of the stepping stones is to make use of the lived experience that people have already who study mental health, psychiatry, psychology, nursing, and so on. Usually, most of us have got some sense of we've come across cases of people that moved us, or we may even have our own experience of mental disorder and so on. And usually these things do motivate us. We're here for a reason. We don't sort of suddenly out of the blues decide to study, mental health disorders in psychology or psychiatry. We've got a reason. So to actually make better use of ourselves and others as stakeholders, so that this experience feeds the richness of the research rather than bias it, is something that I very much hope for the future. As you may know, in the arts, the idea of me search is used in a derogatory manner sometimes, meaning
Mm.
that you're biased in your research because of your own personal experience. I
Yeah.
study depression and I've got a particular idea about depression that I want to prove because this is my experience of depression and I'm sort of blinkered about it. Um, so it's used in a negative way, and I hope that if we involve people in this conversation that are stakeholders and we're open about it, it'll help both destigmatize, but also break down the stereotypes that scientists have um, uh, about mental health disorders.
Mm. Well, that is so cool. And yeah, I'm really, really excited and looking forward to what this field has to offer. But yeah, thank you so much for speaking with me. It was really a pleasure. Yeah.
Great pleasure, Benjamin. Thank you very much.